As we conclude this scientific program for today, the last session, session 4, the session is on complex clinical condition, safe anesthesia practices. And to conduct this session, I'd like to invite Dr. Malika Hamid to come on stage and conduct the session.
Assalamu alaikum. Welcome everyone in Complex Clinical Conditions Safe Anesthesia Practices session. I am Dr. Malika Hamid, Senior Instructor and Consultant Anesthesiology from Aga Khan University Hospital, and I will be the moderator of your session today. So, firstly, I would like to welcome our honorable chairs for this session. Professor Muhammad Ashraf Zia. Please come on stage, sir. He is head of Department of Anesthesia, Critical Care and Pain Management at Allama Iqbal Medical College, Jinnah Hospital, Lahore. He is also Dean of Anesthesia at College of Physician and Surgeon and Senior Vice President, PSA Lahore Chapter. He is Supervisor and Examiner at UHS and CPSP. Secondly, I would like to invite Professor Naila Asad. Please come on stage. She is Head of Department of Anesthesia, Services Institute of Medical Sciences, Lahore, and member MS Anesthesia Committee, University of Health Sciences, Lahore, member and supervisor of Anesthesia, examiner, paper setter at College of Physician Surgeon, Pakistan, and Vice President, Society of Anesthesiologists of Pakistan, Lahore chapter. She has numerous national and international publications. I would like to request our chairs to invite the first speaker and start the session. Thank you.
Bismillah ar-Rahman ar-Rahim. Thank you very much. Our first speaker is Dr. Kamal Al-Naimi from UK. He is consultant anesthetist at Royal Free Teaching Hospital, UK. He underwent training in Mercy, Liverpool, UK, and holds fellowship in critical care, cardiothoracic and upper GI anesthesia. He has been practicing as a consultant anesthesiologist for 16 years and sit on the European think tank for minimally invasive esophagectomies as anesthesia representative. So his topic of presentation is anesthesia for minimally invasive esophagectomy. Please.
Thank you. Assalamu alaikum. Thank you for the invite. Today I'm going to speak to you about minimally invasive esophagectomy anesthesia, which is a topic which is very close to my heart. I've been doing it for about 15 years now, from the anesthesia perspective. I've got two disclaimers. One is I do work for Medtronic as an expert in anesthesia for this specialty. I don't get any royalties for that. And I have pinched quite a few Google images which I haven't referenced properly because there's so many. So this is going to be a very quick run through this topic. I'm not going to go into specifics because it would take probably a whole session of 3 hours. So this is just going to be an overview. So what esophagectomy is, for those who don't know, sorry if I'm teaching you to suck eggs, but esophagectomy is where we remove the esophagus, which is cancerous, by cutting part of the stomach and creating a new esophagus and cutting the top end of the esophagus and then cutting this bit out through the thoracic, usually, region, and then anastomosing it behind the sternum if it's a low cancer, or in the neck, usually as part of a McEwen's procedure if it's high positioned cancer. The traditional cuts are these. As you can see, Ivor Lewis, usually a laparotomy with a thoracotomy, right thoracotomy. With the McEwen, there's an added neck dissection as well. And for the transhiatal, usually just a laparotomy and a neck dissection. For the minimally invasive, usually laparoscopy. So it starts off with laparoscopy between 4 to 6 punctures, and then the patient's shifted onto their side with video-assisted thoracoscopy when the esophagus is removed from the chest. The process takes about 8 hours, but now we've got the innovative robot which has come into play big time, and a lot more of these esophagectomies are done by robots. So I'm going to speak in the context of enhanced recovery after surgery, which was founded by Henrik Kellett, in the mid-1990s to late 1990s. And that's become something that's accepted as a means of managing patients and expected as well. This is what is proposed as part of the Enhanced Recovery Program. It may look very busy, but really the essence is focusing on the patient, trying to get the patient better and fitter for the operation. So we get them to exercise, improve their nutrition before the operation, inform them and educate them about pain and what they need to do, and manage the stress response as well. So I'm going to tell you how. So there's a concept of marginal gains where you try and improve every aspect of your practice. Even the minimal amount of improvement leads to a massive improvement later on, which is called the aggregation of marginal gains, which is something that was popularized by Sir Brailsford in the UK. So I'm going to talk about pain and the impact. I'm not going to go into depth. So severe pain, moderate to severe pain can lead to increase in, or will lead to increase in sympathetic response and cardiovascular effects leading to tachycardia, hypertension, and that has an impact on the heart and the brain mainly. So you do get dysrhythmias, could get a heart attack, could get strokes or TIAs, which we try and avoid. It can affect the lungs as well, as the patient, if he's got severe pain or she's got severe pain, will impede the cough and expectoration, which leads to consolidation and potentially chest infection. And also neuroendocrine system through insulin resistance can lead to an increase in blood sugars and the stress response increasing the steroids. The cumulative effect will lead to infections anywhere in the body, which will, as well as DVTs because of lack of mobility, which increases the viscosity, plus the surgery and the stress response. And all of these slow down the recovery process and the journey towards going home. Let's not forget, especially with thoracic surgery, it's renowned for causing chronic pain as part of the side effects. So analgesia, what is our target for analgesics? Well, we need them to be comfortable, reduce the side effects of them, or no side effects preferably, and should be user-friendly. So the comfort is so that they can take deep breaths, can cough, and mobilize. We reduce the side effects, which are the known ones are shown up here, with low blood pressure, tiredness, nausea, sickness, and constipation. Also, we need something that both patient and the nurse or the people around them can use pretty easily. So we know the pain pathways, and there are lots of painkillers that are used for this purpose. I'm not going to go into details, but what we need is really a bit of everything to minimize the side effects that may be produced if we use one drug more than another. So we tend to use small bits of drugs and try targeting the various points within that. So we use it preemptively as well, preferably. There's some evidence it can reduce chronic pain. So I'm going to speak from my experience and what we did. So when I started doing this about 15 years ago, there was a lot of literature out there, but nothing specifically for minimally invasive esophagectomies. So I looked at the research. There was a lot of noise, as you can see on the left side. And then gradually we came up with some sort of concept, and we started doing these MIEs. And with time, it gradually sort of, stabilized, and we had clarity and focus in what we were doing. So the journey of the patient goes through these main processes, not specifically, there are lots more processes, but just to break it down simply. So they usually go through an MDT where the clinicians involved in that, including myself, will decide on the chemo-rad, and as well as informing the patient, educating the patient on what is going to happen and the process. Between chemo-rad, there's a small window of opportunity, about 6 to 8 weeks before surgery is actually done. So during that period, we do a prehab. So for prehab, we involve the physiotherapist to give them some exercise protocols to follow, which includes cycling and brisk walking. Also, we teach them deep breathing exercises, and that's for after the surgery. And nutrition as well, so dietitian gets involved, and they assess the patient using the MUST protocol. They set a low-fat diet, high-protein diet, trying to build up the muscles of the patients, reduce alcohol if they're drinkers, and no nicotine products, including patches. And the well-being, which is quite important because these patients are stressed, so we include the family in lots of the decision makings and also during all of the chats, whether it's with the surgeons or with the anaesthetist. We also educate them about pain, and we repeat everything we've told them before, and that keeps happening. We also optimize the patients, especially from the perspective of high blood pressure and diabetes. In the pre-op assessment clinic, they're seen by nurses who take bloods, they do the basic checks, plus we do a CPEX test just to make sure that the patient is fit for the surgery. It doesn't necessarily make us prevent the patient from going. We get them fitter to get to the surgery. We do our regular anesthetic consultation, and we repeat the same things that we expect out of the patient: to quit smoking and alcohol and to do their exercises in preparation for the surgery. The night before, they can eat a normal meal, and we continue with their normal medications, start them on dual anti-acids, PPIs, and we give them a carb loading in the morning. And there's a lot of evidence, which I'm not going to go through, about carb loading and the benefits of that, especially with regards to the insulin resistance and the breakdown of muscle. On the day of surgery, the anaesthetist, which is usually myself, takes them to theatres. We hook them to the monitors, a couple of big Venflons. I put the arterial lines while they're awake on the local. I do a spinal and then hook them up to a BIS monitor. I start them on either Tiva or gas. My preferred one is Tiva, but gas I used to do with desflurane. Put double lumen tube from their word go, and usually left-sided. I don't inflate the bronchial cuff until the thoracic phase is done. There's some evidence that propofol Tiva does reduce the recurrence of cancer, and that's why everyone's shifting to that, including the cleaner nature of it as well for the environment. Chloramphenicol is used for the eyes. We put an NGT with a bridle so the patient doesn't pull it out. Urine catheter, temperature monitoring, as well as warmers. And I do not put an epidural in, I do not put a central line in, and I don't give them TPN or jejunostomy. And I'll tell you later why. So epidural is long thought of as the gold standard of analgesia for thoracic bowel surgery, and it does give fantastic analgesia. However, there is a failure rate, whether it's disconnection or kinking or whatever. Lots of side effects, including weakness. And weakness is not good because the physio is too scared of moving the patient. So the patient is too scared of moving out of the bed as well. Also, not moving leads to complications and increases the length of stay in the hospital. Also, the epidurals can lead to low blood pressure, which makes us give them either inotropes or fluids. And inotropes and fluids can lead to ischemia or edema in the anastomotic site, which can lead to dehiscence and perforation. We know that the pain in robotic or even minimally invasive is a lot less than open. So why should we be using epidurals? There's a lot of evidence coming out that we shouldn't be using epidurals, which there are lots of other alternatives. Central line, I don't put in, again, for the same reasons, side effects. There's a lot of evidence that contradicts fluid management based on on central lines. And it's an easy way of putting inotropes, which we're trying to avoid. TPN, so what do? How do we feed the patient? I'll come to that shortly. So my analgesia is to do preservative-free morphine, 100 to 300 mics only, spinally, diluted in saline, no local anesthetic. I use a Remy fentanyl infusion, and there's a lot of evidence about morphine use in the spinal or subarachnoid space. I use paracetamol, occasionally Voltarol, definitely magnesium, up to 5 grams, and fentanyl towards the end of the operation. We do preemptive local anesthetics in the abdomen before any of the ports go in. We do intercostals as well before the thoracic phase. Subpleural, paravertebral catheters are inserted by me or the surgeons, and there's a lot of evidence to support that. We did a study as well which showed actually better outcomes. There was a meta-analysis that we did a few years back, a couple of years ago actually. There are other blocks on the block, serratus anterior plane blocks and pec blocks, as well as erector spinoid blocks. Lot of evidence coming out for that. Central lines, we use goal-directed therapy, though the evidence is not quite there, though they're very good at monitoring and giving us a trend for the, we don't use jejunostomy because we've had so many complications, so we've actually completely avoided those. We extubate the patient at the end of surgery. They go into recovery, hooked up to a PCA and the paravertebral infusion, and we give them antiemetics. They start taking deep breathing because we've trained them to do that, mobilize as well, give them water in recovery, and there's a lot of evidence, including some of our group's research, that actually proves there's no harm in doing that. It may actually be beneficial. They're transferred to HDU. We start them on carb juices and get them out of bed as soon as they get into HDU. No inotropes are used as much as we can, and fluids. They spend the day in their HDU, discharged to the ward, and it's glitched, yeah. Then we give them soup, jelly, and ice cream on day 1, post-op, and they keep mobilizing until they're discharged in 7 days. We have actually managed to discharge them as little as 4 days. As you can see, there are lots of people who are involved in the process who are vital. So we've created champions who I used to chair on a weekly basis just to make sure everyone highlights any issues. And that without this teamwork, this would not be successful. And there's a lot of evidence that integrated care pathway is mandatory in things like this. As Don Lowe actually said, who's one of the gurus in esophageal surgery. So in summary, collaboration, getting the people and champions on your side, they're the ones who actually push your word forwards. And you can't do this alone. You will have to have a whole cohort of people supporting you. Integrated pathway is integral in actually making this successful. Managing every aspect of this protocol is very important. Don't forget the small things that make a big difference. Attention to detail, knowing what to change and how to change it, gives strength to what you're actually doing. And lastly is develop an enhanced recovery program. Without it, this will not succeed, and you will not manage to get these patients through in a short period and with safe outcomes. And keep on dreaming, which is an acronym for drinking, eating, and moving. And as Leonardo da Vinci said, simplicity is the ultimate sophistication. Looking at the details can actually help out the outcomes. Thank you. Any questions? Thank you.
Thank you very much. Please have a seat. We will have question answered at the end of session. So our next speaker is very vibrant anesthesiologist, very good friend of mine, Professor Jodhislim. He is holding a lot of key posts, but I would like to give brief introduction over here. He is Professor of Anesthesia, ICU and Pain Management. He is Head Department of Anesthesia, Postgraduate Medical Institute, Lahore General Hospital, Lahore. He is also serving as holding additional charge of Executive Director and Medical Superintendent of Punjab Institute of Neurosciences. Currently he is President of PSA Lahore Chapter and member of Executive Council of PSA Pakistan. He is member faculty of Anesthesiology, CPSP. He is supervisor, examiner and paper setter at CPSP, UHS, Fatima Jara Medical University, King Edward Medical University and Pakistan Institute of at PIMS. So also he is holding many other key posts, but that's his brief introduction. Kindly give a big round of applause to Professor Jodha Salim.
Thank you very much. Assalamu alaikum and good afternoon. First of all, I would like to thank the PSA Karachi for inviting me for this talk. And my disclaimer is that I am not a practicing pediatric anesthesiologist. Madam, you're up. So, in next 15 minutes, I try to cover the epidemiology and statistic of the pediatric polytrauma and how the trauma triage is done and what are the different scoring systems which are used to predict the morbidity and mortality in the pediatric patients. Then we'll look for the evidence, what are the balanced hemostatic resuscitation solutions which are used in practice these days, and what are the different steps of the peri-operative management of these patients. Management of hypothermia, which is a major concern in the management of pediatric patients, then ultimately will touch the specific regions of major concerns in the pediatric polytrauma. Trauma is the leading cause of death and disability in children of less than 15 years of age. The problem is not just confined to the developing countries, but it's a major issue in the developed countries as well. To my surprise, when I was searching the internet, I just came to know that there is more than 600,000 deaths are reported each year globally. I didn't have any idea about that. And trauma-related deaths are more than 10,000 in USA. And when I tried to search for the local data, I was unable to find any significant paper on that. Then I'll touch the professor at Children's Hospital Lahore. Unfortunately, they didn't have compiled data about pediatric polytrauma. In the center where I'm currently working, we are dealing with the neurotrauma. And on an average, we receive 3,000 patients per month. And out of these 3,000 patients, 30% of the patients, they are less than age of 15 years. And out of these 90%, they are the victim of the bike accidents and that chingchi and rickshaw and all that. Now coming back to the international data, 50% of the patients, they die at the scene from the extensive head injury or the hemorrhage. 30% they die in first few hours from the head injury, hemorrhage and airway emergencies. And there are late deaths which are reported due to the organ failure and sepsis. The leading cause of the traumatic brain injury, hemorrhagic shock, and that is due to the thorax and abdominal injuries, motor vehicle, bike accidents, immersion injury, domestic violence, homicide, suicide, firearm injury, they are the main causes of the pediatric polytrauma. How we can play a major role or a vital role being anesthetists. So you can help the initial stabilization in the ER. We can provide sedation, monitoring for the imaging. And then emergent surgical procedures like thoracotomies or craniotomy or abdominal laparotomies. Then semi-elective surgeries once the patient has been stabilized. This is I'm talking about the fixation of the fractures, pain management and ICU management. Now, what are the various challenges of managing a pediatric polytrauma patient? The main focus is on the airway and the IV access. And if somebody who is not regularly doing pediatric as a discipline, it is a nightmare for them. I will not say a challenge, it will be actually a nightmare for the anesthetist. So if you don't have a trained personnel, you don't have an infrastructure at your center, just resuscitate, stabilize and immediately shift to the patient to a heart center where these facilities are available. Now, how pediatric patients, they are different from the adult patients. So the main issue is that they have a smaller body mass as compared to the adults. And why they got contracted into various injuries. They got always, with the polytrauma, they have multiple injuries on board. So the reason being they have a greater force of impact as per body unit area. And their multiple organs, they are in a close proximity to each other. They have less fat, they have less connective tissue. Their muscle mass is not mature enough and strong enough to prevent the injury. Similarly, they have higher incidence of blunt brain injuries due to the proportionately larger size of the head as compared to the body. And obviously the increased risk of the hypothermia in the pediatric population. So what we can do and how we can help in these pediatric polytrauma patients, what we can do is if we can get hold of an airway and we can try to get hold of the IV line and spinal immobilization. But the last 2 points, they are very, very important. And that is the shortening the time interval between the injury and transporting that patient to the definitive care area. And number 2, it is very, very important is you should not delay the transport to the definitive care instead of waiting for putting an endotracheal tube and managing an airway or trying to get an IV access. So how trauma score help us? Basically, they help to identify the severity of the injury and they can predict the morbidity as well as the mortality. So various scoring systems are used, but the two main which are used are the pediatric trauma score and the revised trauma score. Revised trauma score of less than 12 and pediatric trauma score of less than 8 are predicted of the morbidity and mortality. I'm just giving you the details of the pediatric trauma, and it has 6 components. That is weight, airway, systolic blood pressure, level of the consciousness, open wounds, fracture. And it has got total of 12 numbers, and with a scoring of 9 to 12, it is minor trauma. 6 to 8 is a potentially life-threatening situation. 0 to 5 is a life-threatening situation, and less than 0 is usually fatal. So we start with the primary survey and resuscitation on the principles as we deal the adult patients. So we go through the airway, breathing, circulation, and once you have got hold of these and after the initial stabilization, then obviously a patient is properly exposed. You examine the patient from head to toe, the back is examined as well, and then you determine the level of disability. While managing the airway and evaluating it, you should be considerate about the cervical spine injury or the possibility of cervical spine injury. Always use manual inline stabilization method, look for the hemorrhage, try to determine the GCS, and always consider these patients as full stomach. Inability to maintain a patent airway along with lack of oxygenation and ventilation is the most common cause of the cardiac arrest. And you just have to look for the obstruction. And most of the time, you just put the patient head and neck in the neutral position, the obstruction is, or you can overcome the obstruction. You have to look for the signs of the external injury, compression, look for the blood, teeth, foreign body, vomitus in the oral cavity. Just try to clear it and try to maintain the airway. So the non-invasive methods by which we can manage the airway is just keep the head and neck in the neutral position. You can use just jaw thrust and bimanual inline stabilization. Section of the secretions and bag mask ventilation can be done, which can be done either by using an oral airway or without it. The indication for the invasive airway, that is putting an endotracheal tube, is a GCS of less than 9, and there are certain papers which say GCS of less than 8. If you don't have a patent airway or there is an impending loss of the patent airway, you are unable to oxygenate and ventilate, and there is a full or there is an impending cardiac arrest, just intubate the patient. The drug-assisted intubation or RSA protocol in this huge slide. There are just 2 points which are of major concern. That is the use of the atropine if you're going to intubate the patient of less than 1 year, and if you're going to use a repeat dose of succinylcholine, you should use atropine as well. It doesn't matter which type of induction agent you are using. You can use etomidate, you can use fentanyl, you can use midazolam, or even propofol. All depends upon the hemodynamic status of the victim. Now, coming to circulation, you have to identify the region of the circulatory compromise. At the same time, you have to determine the weight and the circulatory volume of the victim. Try to obtain an IV access and what are the different choices. And administering resuscitation fluid and blood products. I'll brief it in the next couple of slides. And finally, assess the adequacy of the resuscitation and keeping in mind achieving thermoregulation while doing all these steps. So you have to identify what is the area of the hemorrhage. So mostly it is abdomen, it is thorax, it is the vascular injuries, and at times retroperitoneal hematomas. The pediatric patient has got a very good physiological reserves, and they maintain their systolic blood pressure and cardiac output unless more than 30% of the cardiac output is more than 30% of the volume is lost. So tachycardia and poor skin perfusion is the early signs of hemorrhagic shock, and if in doubt, just get a consultation by the pediatric surgeon as soon as possible or as soon as he's available. So you can see here the heart rate is the first sign which start to increase with the hemorrhage, but blood pressure and cardiac output, they are reasonably maintained till the 30% of the total blood volume is lost. Regarding venous excess, whatever venous excess you can get, try to achieve it. Generally, antecubital fossa and saphenous vein, they are an easy to approach. If you're unable to get an IV line, you can try an interosseous IV access, and that is done in the intermedial tibia or the distal femur. You can get a central venous access, and again, it depends on the expertise. You can go for a femoral vein, EJ, IJ, or subcutaneous, whatever is available. And somehow, if you're not able to get hold of IV line, go for a cut-down, get the help of the surgical team. Look for the clinical signs of the shock, which are generally evident after 30 to 45% of the loss. Start with giving first bolus of 20 ml of isotonic crystallite fluid. You can go for an additional bolus of 20 ml per kg of the isotonic fluid. There are certain articles which state go for a third bolus, and there are the damage control resuscitation say that you should be after a couple of boluses you should start using the RBCs and the coagulation, the Paxil volume as well as the FFPs and platelets. All intravenous fluid should be warmed to the 37 degrees. Resuscitation, isotonic crystallite fluid is a choice. Hypertonic saline can be considered for head injuries, and you can use choline and albumin if you're not getting hold of the blood or the products, and dextrose-containing fluid, they should be avoided. I'll have to skip it. It's a long presentation. Regarding disability, you have to look for the level of the consciousness. If a GCS of less than 8, patient is in need of a definitive airway, and GCS of less than 5 determine the poor outcome. Examine the cranial nerve, look for the pupillary responsiveness and motor strength in each limb. Once you are done with the ABC and D, then you expose the patient, as I've already mentioned. Examine the patient from front, from back, head to toe, identify the injuries, control bleeding by the direct pressure, air splint on the extremities, a rectal temperature probe should be used, and cover the patient while you are examining it. Regarding preoperative evaluation, just quickly go through the ABC, go for a relevant history, investigation. You need just hemoglobin, hematocrit, you need coagulation profile, and blood grouping and cross-matching. Clinical examination and re-clinical examination is very, very important, and imaging in laboratory should not delay the emergent procedure. Regarding head trauma, indication for a neurosurgical consultation, bulging frontalis, sutured diastasis, GCS of less than 8, and if patient is persistently vomiting, amnesia, anesthesia, you should look for a neurosurgical consultation. The GCS is slightly different from the adults. Coming to the thoracic trauma, 8% of the trauma victim, they come up with the thoracic injuries, and mainly it is due to the blunt trauma. Immediate and imminent life-threatening injuries are the tension pneumothorax and pericardial tamponade. So go for a pneumothorax, for pneumothorax and hemothorax, go for a chest tube. And regarding if you have a penetrating thoracic trauma, your patient is hemodynamically stable, go for a thoracotomy. Regarding intraoperative course, you should use standard monitoring. Temperature monitoring is mandatory and try to cover it. For specific injuries like hand injury, you can go for intracranial pressure monitoring, invasive monitoring, and neuro monitoring. The maintenance of anesthesia can be done by the principle of balanced anesthesia. You should be using adequate hypnosis, analgesia, and muscle relaxation. No single technique is superior to the other, and TIVA is gaining popularity. Regarding postoperative period, shift these patients to ICU or HTU, whatever is feasible. Monitoring should be continued, and challenges are fluid shift, acidosis, soft tissue swelling, mechanical ventilation, neuro cases, facial trauma, and airway. They require mechanical ventilation. I'll finish my talk here, and the last slide. PSA Lahore chapter is going to hold its annual conference on 26th to 28th of April, and we are looking forward to welcome you in Lahore, inshallah, on these dates. Thank you very much.
Now, I would like to invite Dr. Asad Latif. He's Associate Professor and Chair of Department of Anesthesia at Aga Khan University Hospital, Karachi, and he underwent anesthesiology training in United States and had a fellowship in critical care medicine at Johns Hopkins University School of Medicine, US. And he's a director of Center for Patient Safety and COVID ICU. He has numerous national and international publications. His research interest is quality of care, adapting quality improvement approaches to novel settings, and evaluating large-scale quality improvement program. He will be talking about frailty assessment and rehabilitation strategies. Dr. Asad. Thank you.
Assalamu alaikum, and thank you very much to PSA for inviting me to talk about this. Now, I have no relevant disclosures, and we're going to spend the next, hopefully, 15 minutes talking about the role of frailty in surgical outcomes, some common approaches to measure frailty, and some potential impact of prehabilitation. So, given that it's such a brief time, we'll touch on these topics and maybe talk about the application and the why. Like most good talks, I'm actually going to try and start off with the why. And the why really is about an entity like this, for PSA, right? It's about anesthesiologists, and why are we talking about this? Because anesthesiologists need to move out of the OR. We need to be practitioners who can effectively identify and assess complex medical needs of patients undergoing surgery. The concept of perioperative physicians has been thrown around. In fact, this is the recommendation of the ASA committee back about 10 years ago, stating that this is what many departments should aspire to. This is the future of anesthesia. It really is, we need to utilize every opportunity to maximize patient benefit, and this is what we do on a day-to-day basis in the intraoperative period. The discussion is whether we can start even earlier, because there is a clear relationship between frailty, better assessments, and prehabilitation, and improving surgical outcomes. And ultimately, it requires collaboration, and who's better at it than we are? Because it does require coordination between various specialties like rehabilitation specialists, geriatricians, and we have the experience not only in the OR but in other fields such as critical care. So, starting off with frailty, when you talk about frailty and surgery, there's tremendous evidence out there. Frailty is associated with worse outcomes, with new postoperative disabilities, unscheduled hospitalizations, and all-cause mortality. There's a lot of studies out there about this. Most of this started after 2001. And there have been studies showing that general elective surgery के बाद almost 60% of patients with frailty needed to go to a rehab facility. Of course, these aren't common in Pakistan, but they needed this. This was as compared to 5% otherwise. It's been shown as an independent predictor for new post-operative disabilities and of increased length of stay. In terms of emergency surgeries, it's even worse. People with high frailty scores were more likely to need ICU admission. They had stayed in hospital almost 10 days longer, and almost 5 to 6 times as many people were sent to rehab facilities after they discharged from the hospital. This has really been most studied in cardiac surgery, where even mortality is increased in people with high frailty. So, why is it important for us though? And we'll get into the concept of what frailty really is. Because the age of patients undergoing surgery is increasing. This has been happening around the world in places like the UK and the US, where it'll increase 2 to 3-fold in the next few years. Even in Pakistan, the WHO estimates that our population, the people over 65 will be 3 times what it is by 2050. We're in some ways victims of our own success also. There have been tremendous improvements in anesthesia and surgical care over the last few decades, and we're able to take care of older and older patients, survive surgeries, undergo surgeries, and survive surgeries. And accordingly, patient and family expectations are changing. They expect people, the 90-year-old who has a hip fracture, to be not only be able to survive that surgery, but to be able to get up and walk around after that. So we need to assess how we can get them there. And ultimately, we know that post-op outcomes are still worse in older patients compared to younger ones. So, what is frailty? It's essentially, currently, the geriatricians call it a syndrome that can be influenced by both the aging process and the disease process. It's a state characterized by physiologic and functional reserve being decreased, and decreased amplitude and rate of response to stressors. And what is a bigger stressor than surgery? However, this isn't the same thing as age, because not everyone who is old or has a medical condition is frail. Similarly, not everybody who's frail has a medical condition or is old. The prevalence of frailty does increase with age though, predominantly seen in people over 65, and almost 25% of the geriatric population is frail by definition. The approaches to frailty are really twofold. One looks at the phenotype approach, and the other looks at scoring and indexes. So we'll get into those. So frailty phenotypes were primarily defined in 2001 by Linda Fried at Hopkins. And what she did is she looked at a big cohort, about 5,000 patients, and they looked at indications for progressive decline that resulted in poor outcomes. Outcomes they measured at that point were things like falls, admissions to the hospital, death even. And they found that a clinical syndrome with 3 or more of the following features were predictive of worse outcomes. So these people were frail. They weren't able to recover as well, as quickly, or to their baseline extent. These features: unintentional weight loss, self-reported exhaustion. She had them all. Weakness, slow-paced walking, low physical activity. They're common. These are common everyday sort of phenomenon that were predictive of worse outcomes. I know I can't take the same amount of call I could 5 years ago even. As we get on in our age, many of us will, many of these symptoms will resound with many of us. This is different from the other approach to measuring frailty, which is the frailty indices. And this is more about the deficit accumulation model, is another way to look at it. And this really looks at the number of deficits accrued over multiple domains over the years, right? It accounts for illnesses, it accounts for the ability to manage activities of daily living, because this is what's really important to patients. They want to, if they're sick, they want to get back to normal. They want to get back to their normal health. They want to get back to getting on with their lives. So the ability to manage active daily living, pre-existing deficits like strokes and comorbids are all accounted for in these frailty indices, in this approach. And there are lots of tools, dozens out there, maybe 80 tools or so, that help define and assess at the same time. That is the difference between this and the phenotype approach, because there are tools that will help not only define it, but also allow us to measure it. The problem with this approach is there's a significant overlap because of the questions, the things that they look at between frailty, comorbidity, and disability. And often we can confuse the three concepts, but they're all interlinked. But when we think about frailty, the first thing I think about is physical frailty. But the conceptual framework behind frailty is more intricate than that, because all these things affect our physical well-being and recovery. Physical frailty is something that we can all identify with, loss of physiologic function, but the concept of cognitive frailty and social frailty also need to be considered, because all of them overlap in the ultimate outcome of importance, which is recovery, going back to normal. So just briefly touching upon the concepts of cognitive frailty, which is a state of reduced cognitive functional reserve caused by physical ailments other than neurodegenerative diseases. And I think many of us can identify with this. जो पहले याद रहता था, नहीं रहता. So many patients in the post-op in the ICU, one of the main concerns is, मुझे वो बात याद नहीं आ रही. I don't feel normal. I can't remember the things I used to. And in fact, this is something that is of tremendous distress, not just to patients, but their loved ones. I'm sure we can all remember cases where patients were brought back from the brink of death after gunshot wounds, severe septic shock, and we pat ourselves on the back, चलें केस से निकल गए, बच गए, और ख़ानदान बोलते सर वो मुझे पहचान नहीं रहे, बहुत परेशान हूँ मैं, 5 दिन से बेहतर नहीं हुआ, मुझे पहचान नहीं रहे. And that is really the type of things that we worry about, actual patients worry about. So that's the concept of cognitive frailty. It's more likely to come back to normal. Will the person come back to full normal? And how long will it take? The third concept is around social frailty, and this is probably the least well-studied one. It's really about the concept of not having the resources to fulfill our basic social needs. And how the best example for this might be how people with better socioeconomic backgrounds have greater expectations in terms of the recovery function versus those of lower socioeconomic backgrounds. Because they just don't have the social resources. It's a poorly studied concept. It's probably related to social need and fulfillment and social resources, and that's why it makes it more pertinent for our community and our country, because we don't have many of these things. We can touch upon the biologic mechanisms of frailty. It's not exactly clear what it is, but the proposed mechanisms are really associated with aging, right? It can go down to the cellular level, where our telomeres aren't working as efficiently and our DNA replication and maintenance isn't as good. It's related to things like immunotherapy, oxidative stress, dysregulated inflammation, cellular senescence, genomic instability, a whole host of things. But the key is it affects all organs, from the brain to the endocrine system, immune system, and the skeletal systems of frail patients. We'll briefly touch upon frailty assessments, and these are regarded as better prognosticators for outcomes than biologic age. It's become part of the routine assessment recommendations of the American College of Surgery and the Geriatric Society. But for us as anesthesiologists, this is important because early identification of frailty can help ameliorate potential effects. Because you can, if you identify them early, you can pre-surgically assign things like rehabilitation, intensive rehab interventions, plan for post-discharge support, or even consider not doing the surgery. I'm going to briefly touch upon multiple frailty screening tools. There's many out there. These are 5 of the most commonly used ones. But they're all different, right? They have different questions that they assess. They come from various sources. They come from the geriatric backgrounds. One of the most commonly used ones is the clinical frailty scale, which is really designed to be a common language among health professionals to define it. It doesn't require physical performance tests, mostly based on questions, based on the Canadians' work on this large prospective cohort they did. And the problem with this is it does require subjective clinical judgment, right? Because the questions really put you on a scale of 1 to 9 now, start off 1 to 7, 1 to 9, which is easy for us to identify. We do ASA scoring, we do various scoring. This makes it easy for people to get risk predictive. I'm going to tie this into the concept of prehabilitation quickly, because why is prehabilitation important? Because we talk about rehabilitation, but we know that there's modifiable risk factors that increase the risk of death and complications after surgery. This affects almost 75% of patients. So 75% of patients, 3/4 of the patients we take care of, have modifiable risk factors before surgery. But often, I find in this community, in this country, we rush to surgery. मरीज हाथ में आ गया, अभी surgery कर दें. Optimize करने का मौका नहीं मिल रहा. अगर अभी नहीं की, कोई और कर देगा. To address prehabilitation, it really needs to shift from the current focus to improve outcomes, because right now we're more of a reactive or an impairment-driven system. We need to move towards a proactive or a prehabilitation-driven system. And because ultimately, like I mentioned before, the most important thing to patients is, the only reason they undergo surgery is to restore function and return to daily life. And prehabilitation and rehabilitation is focused on post-op, but they can start doing something preoperatively, because let's face it, post-operatively, you're in an immune-compromised state, you're in a catabolic state. It is not the best time to be building muscle, to be building rehabilitation, and to be getting stronger. So the conceptual framework behind this is really analogous to distance running, marathon training, right? You want to have structured, sustained exercise over days to weeks to build up your physiologic reserves, to build up your cardiopulmonary function, build up your muscle function, to fix modifiable risk factors that can take longer, and ultimately have better functionality and decrease frailty so that you can do that. The scope of rehabilitation interventions is tremendous. You can look at physical activity, exercise tolerance, nutrition support, pharmacologic, respiratory interventions. But when we look at this and study this, there's 4 basic things that we can do that have been associated with improved outcomes. And the improved outcomes being reduction in complications, especially pulmonary complications, and decreased length of stay, and decreased infections. So inspiratory muscle training, exercise regimen around inspiratory muscle training has been shown to do a 45% reduction in post-op pulmonary complications. Similarly with exercise, and this is a simple exercise tolerance, increasing your steps over the course of time, about 5,000 steps preoperatively. Immunonutrition, so modifying nutrition to change your gut biome, has been associated with a 37% decrease in total infective complications. And this was results of meta-analysis. And ultimately, all these things result in almost a 2-day decreased length of stay. Here's the data from the meta-analysis. You can see when you look at reducing length of stay, these 4 things were significant. Post-op complications, total post-op complications, multimodal is always best, doing more than one, don't do one at a time. Exercise, IMT, decreased post-op pulmonary complications, and pre-admission intervention reducing pneumonia overall were a little equivocal. So, in conclusion, the reason for having this talk is really because anesthesiologists are leaders in collaborative perioperative care. That has to be a main take-home. And to do that, to really be perioperative physicians, we need to focus on more than just the intraoperative period. Frailty is a great way to think about these things. It's a better predictor of surgical outcome than age and comorbids. And prehabilitation has been shown to improve outcomes to patients. So we need to incorporate both in our clinical practices, and I would actually urge that these are areas for research in our population that have far greater impact than the smaller studies we often focus on, looking at things like propofol and etomidate. This is the area where we can really help our population the most. So with that, here's my references, and thank you very much.
Now I would like to invite Dr. Khalilullah Shibli. He's currently working as Senior Consultant Anesthesiologist and Pain Physician in the Department of Anesthesiology, Intensive Care and Perioperative Medicine at Hamad Medical Corporation, Qatar. He's Clinical Assistant Professor at College of Medicine, Qatar University, and serving as Director, ECG MEI Anesthesia Residency Program at Qatar. And he would be talking about pre-operative assessment of complex cognitive exercise.
Bismillahirrahmanirrahim. Thank you very much, PSA, for inviting me. We have heard a lot of science, So I just want to ask you one thing, actually. नहीं आ रही है। Just tell me who is not familiar with this music, because this talk is all about art. It's not about the science. So whoever is a novice is a scientist, and people sitting in front of me, the experts, they are artists. So the scientists are going towards to become the artist, basically. So it's not a medical science discussion at all. No conflict of interest, obviously. These are my hospitals where I work, like 10 hospitals in Qatar. They're obviously high-tech system. What we are going to be discussing is about the pre-assessment, which is a very important area for patient safety. If you don't start right, you don't end up right. So you have to start right. So don't read the slides. There are 3 steps in assessing any situation in cognitive science. And that is, you think and think critically, number 1. Then you do the reasoning strategies. And the third one is the decision making. So while you reach decision, actually, you have gone through these 3 processes. And preoperative assessment is one of those things. So we'll discuss the factors behind it. And I divided as novice and experts. So the novice is the scientist, remember that. The experts are the artist. It's a very famous line of the Karl Popper, which says science leading to arts. I call it anesthesia. So what are the problems associated? Let's go quickly. I mean, you are all familiar with it. Seniors are familiar with it. Oh, that's insufficient. They're taking too much time. We don't get more information, poor communications, omissions from the pre-assessment. So we see all and heard all that thing. So our learning objective is to talk about the thinking skills, reasoning strategies, and how to make good clinical judgments and avoid errors. And the theme of the conference is improve patient safety. So this is a part of the workshop which requires interaction. So I'm open to, after the talk, anybody can talk to me about the online workshops if you want to do it, because I like interactions on that one. So there are 2 types of errors, and this is all science. It's not I'm making it up. So thinking error is the cognitive errors, and the technical errors and the technique errors. You can divide that into very easily in your daily practice. Where is the thinking error involved? What is the technical error involved? Where is the procedural errors involved? So I'm least bothered about the procedural errors. I couldn't do the line, he couldn't do the line, she can't do that one. These are very trivial things. Thinking errors are the most important one. Now this, I'm going to go very quickly. Thinking about thinking, as a scientist, you have to develop this. It's called metacognition. It's about thinking. And then, you see, when there is an error in patient safety, you're always discussing in hindsight. You never say, this error is going to happen. Always errors, morbidities, mortalities are discussed in hindsight. So that's a very important point here. And pre-assessment in the middle. So in clinical reasoning, from the thinking point of view, you reach a point where you have a cognitive error-prone zone. When you apply your reasoning strategies and you decide this is the management or the treatment strategy, or the anesthetic technique, you may call it. So, I'm sorry I'm rushing through this slide, but these ones. So metacognition is of thinking about thinking, and studies of the metacognitive training have demonstrated improved decision-making process and decision outcomes. So what I'm encouraging here is to think. That's very important. Think, not alone, together. And the features of the metacognition is, because we think and we do not think about the thing, there is a problem. Because metacognition or thinking about thinking recognizes the limitations of my memory, ability to reflect on, appreciate a broader perspective after discussion with others, and good capacity for self-critique and harnessing overconfidence, and ability to select specific strategies for the best decision making. Now, the cognitive errors or thinking errors are the thought process errors or the thinking mistakes, essentially. And very important thing, very interesting thing is it's not due to the lack of knowledge. Sometimes knowledgeable people make insufficient decisions or incorrect decisions, if I may say so. So it's not the lack of knowledge, but the research says it's the faulty knowledge or the gaps, poor understanding or the gaps in the knowledge, the missing points, missing things. The cognitive versus technical errors, research shows that the technical errors account for only a small fraction of incorrect diagnosis and the treatment. Most errors are mistakes in thinking. I was discussing this airway failure matter with some UK airway gurus. And I said, how many times the deaths who are reported in the airway is due to the difficult airway? None. They're all thinking errors. delays, error of premature closure, things like that. So the problem we discussed earlier on, cognitive errors, is always described in the hindsight. Now you cannot study or research errors in the prospective studies. How can you say this case we will look for the error? You can't look for the errors. And obviously it's very difficult. Simulation is one thing where you can plan and you can do these things. Why their thinking errors are difficult to recognize? Because I can't read your mind, you can't read my mind. Procedural errors are very visible, like, you can see what is happening. So thinking errors have low visibility, low awareness. You can hide it and you cannot disclose it. They're not conducive to root cause analysis, and they're potentially highly preventable. And they're thought process errors. And thought process errors are because of the failed biases or heuristics. My gut feeling is I will do this and I will do it. And that's it. Maybe I may be wrong. Clinical decision making in anesthesia especially has to be very swift. You have to be diligent as well, swift and accurate as well. So swiftness is one thing that kills everybody. And it requires skills to apply in the thinking timely, appropriately, and simultaneously. Now, this point is important. This is from the cognitive science. There are two thinking systems. Clinical reasoning strategies are divided into two distinct thinking systems. Pattern recognition and the analytic processing. So the scientist, what do? They analyze. You guys analyze. What do? We recognize the patterns. So system one processing is a fast, automatic, non-analytical, contextual, intuitive, reflexive, and heuristics with minimal cognitive load. There is no pressure on it. I receive a phone call about a patient and a very comprehensive detail about a patient from a resident, and I stop thinking in the middle because I'm picking few things in the queue. And then I said, okay, these three things we are going to focus on. So that is where we prematurely sometimes close, but this is the reality. Heuristics and gut feeling, they count. System 2 reasoning is slow, considerably scientific, reflective, deliberative, and analytical. And this is, go and read Cross-Carey. The whole aviation science is based on the cognitive theories, and Cross-Carey is one of those who described very nicely on that one. So who is scientific? Who is reflective? The person who is doing the pre-assessment and informing me. And who is reflexive and quick in making decisions is me. But why I'm making all these decisions wrong? So thinking are two types: automatic pattern recognition and analytic and the critical thinking. Learning is obviously we do with the senses, but we expect a resident or a trainee to give me a full reflective account with the reasoning, to make my job easier, to be quick and diligent. And most of the time experts are not wrong. How do we perform in practice? Similarly, reflex, react, and then reflect, response with reasons, and reflective practice is more than one layer of reasoning. So you discuss when some case, it's not a bad thing, it's a very good thing, because you're adding the reasons, layers of the reasoning on top of it to make it more robust, the decision. And most of the time, it's not the residents or the trainees or the reflective practitioners do. They don't do it. It's us who normally takes it to a further level. Research is the same, it's the same reflexive practice. Now, what is this? It has so many things on the top. That means these are the sources. Who utilizes that? Novices. They look at the patient, they examine the patient, and after that, they decide, go to the books, call somebody, internet, all these things. What is this target saying? This is me, or if I claim myself to be an expert or senior. So experts rely more on system 1, intuitive and reflexive reasoning style, which is a pattern recognition. Pattern recognition's example is you drive from home to work and work to home. And if somebody says, can you bring on the way something from a shop or something, and then you forget, because there is a pattern of coming and going from home to. So why it's happening? This is a time thing, time required to make a decision, time constraint in a reflexive, supported by prior experiences, illness scripts, and the knowledge. No time constraint is a reflective. So when you go and see a patient preoperatively, you have no time constraint. But if something comes to me and it is an emergency, then it is very reflexive. I have to act. I have to give a plan to you. And that is based on illness scripts. You can Google all that, because illness script means you have to have enough experience to go back and tap your memory and look at it. But reflective, you have to be history in detail, futuristic look, consult experts, access resources, deliberate practice, options, so blah, blah, blah. All those things are the pre-assessment or pre-operative assessment of any examination of a patient by a novice or the scientist, I would say, better word. Who practices evidence-based medicine at one stage or utilizes? Novices. Novices. They come to you and they tell you that, you know, I read this paper, that paper, these are the guidelines and all that. Versus experts, you utilize the experts, and it's not wrong, because they have illness scripts behind practice-based evidence. They use it. And they supplement from your assessments and from your research, and they say, okay, fine, we can do. So when the experts change their mind about a case management, why do they do that? How do they do that? I was asked once that I don't have a mind of my own because I'm fluctuating. I'll say, okay, do this, do that. Okay, no, you new information. Okay, change it. Why do we do that? Now, the biggest question is, can we let the novices remain reflective? Or can we leave the experts remain reflexive? No. We have to train them to be able to switch between these two thinking systems. We have to train them. So novices have to be trained when they can be reflexive. And us experts, if I claim myself to be an expert, have to train ourselves to calibrate our decisions in the light of the new evidence. And so obviously novices do not possess freshness, illness scripts, so they're not enough exposures, case log, blah. I will leave this slide. It's research only. And then there are some papers which clearly says that balancing strategies is very important between the two. So scientists or the novices cannot remain reflective all their life. They have to have a process called dual processing. They have to learn dual processing and switching and balancing strategies. So if I'm offered, I promote system 2 reflective processing amongst experts, experienced physicians, to prevent premature closure. Premature closure is an error, it's a cognitive error. So I train people in my practice, in workshops, the experts to be reflective, to sit down, calm down, just wait a minute and think about the evidence. Similarly, I teach system 1 reflexive processing for novices by teaching them how to be a dual processing or how to do a calibration to avoid error of comprehensiveness. What is error of comprehensiveness? You say, what is it? I'm comprehensive, I'm good, I've done a good examination, history taking, everything. I'm very good. No, error of comprehensiveness is something which your script tells you that it is a trivial thing. I came across somebody who had a very, very high TSH and a fit and well patient. And the only information given to me, high TSH. When I went to see the patient, his airway was very difficult. So that was missed on that one. So that's the error of comprehensiveness, the ultimate. This is very important, but I'm going to go and make sense out of it. It says all these on the top is the experts, on the bottom is the novices. And you look at the novices, education, training, critical thinking, logical competence, rationality. And the other one is the hard wiring, aberrant conditions, context, task characteristics, age experience, affective state, gender, personality, and all that. And they all lead to something called calibration. Calibration. So before you reach a diagnostic reasoning or diagnosis or a treatment plan, you have to understand there is a period, there's a time of calibration. So how can we teach or learn switching between the two systems? By recognizing faulty knowledge, faulty data gathering. This is from the research information. We all know how to do that. Premature closure for experts and errors of comprehensiveness for the trainees, residents. So obviously, these are not knowledge deficit. Um, I think the message is gone. That's why I'm going to just rush through it. So decision making via rationalization. So for the residents, trainees, it's like history, examination, investigation, diagnosis, treatment, management, and decision making obviously takes place. Wild guesses, from wild guesses, which is called heuristics and the biases, you look for cues to reach the diagnosis, investigation, differentials. This is a normal process we all go through for the decision making. This is a little bit of science here actually. What causes the cognitive errors? Our inner feelings we do not really admit to and often don't even recognize. It happens. There are some disruptive issues with our patients. There is a research, patients make you nervous sometimes, especially the way to prevent thinking mistakes is not to stop thinking, but to think hard again and again, collectively, and reviewing decisions frequently. And think more or think differently. So that's, I finish, and if I have a time very quickly, because I'm a residency person, so I like to just show you some pictures of the happening residency program we have, hands-on thing of objective structured examination. We have a very organized system there, and it's a very happening. So there are from some of the slides of our simulation, debriefing, ITE exams, faculty development, and connections, including Pakistan, USA, UK, Australia, Singapore, Hong Kong, Taiwan, Thailand, Vietnam. We all have collaborations with that one, very good ones. We do regular faculty development workshops like this one I'm presenting here, and we give them awards, like you encourage people to our assessment leads. There's a huge faculty involvement, engagement there in these processes. It's like you, it's like really PSA. I've learned, I've grown in this atmosphere. Whatever I am is because of the activities I have done in the PSA here. And we interact formally, we outreach for these experts, and we have a system of awarding medical education to and anesthesia is one of the best of residency program in Qatar, by the way. It's like for the whole of Qatar, there's one program, and out of 40, 50 ACGMEI recognized program, anesthesia is one of the best ones. Thank you very much for your attention. Thank you. And this is a little abstract already here in the PSA letter about the preoperative assessment complex cognitive exercise made simple. And anybody wants to do a workshop material, I'm quite happy to do that one. Thank you.
Yeah, thank you very much. Our next topic for presentation is management for patients with right ventricle dysfunction, presenting for non-cardiac surgery. And speaker is Dr. Haris Chauhan, and he is FCPS anesthesiology and FCPS in cardiothoracic anesthesia. He is currently working as assistant professor in the Department of Anesthesia and SIUC at NICVD Karachi. Please start.
Thank you, sir. Thank you, PSA, for giving me the privilege to talk on this topic today. Assalamu alaikum, everybody. This is my disclosure statement. I have no financial relationship to disclose. Over the passage of next few slides, we'll be talking about right-side heart failure and pulmonary hypertension. And whenever we talk about the perioperative management, we divide simply into three subtopics. That is pre-anesthetic management, intraoperative management, followed by the most important thing, post-operative management, which is easily being ignored. Starting with the introduction, as far as the right-sided heart failure is concerned, right-sided heart failure, along with pulmonary hypertension, presents with unique challenges. So, involvement of multidisciplinary planning before the surgery is a necessity. The anesthesiologist must ensure from the physician and the surgeon that careful considerations have been given to the surgical benefits with regard to the status of the patient, keeping in view the risk and benefit of the patient. Right-sided heart failure often presents with pulmonary hypertension as being the most common etiology, having left-sided heart failure in the background. Other causes of right-sided heart failure includes tricuspid regurg, pulmonary stenosis, and pulmonary regurgitation, along with cardiomyopathies. This is one of the study of Kaplan-Meier survival study, which clearly showed in the graph on the left side that one of the major causes of right-sided heart failure or right ventricular dysfunction is actually left ventricular dysfunction. which ultimately ends up having congestion or congestive heart failure. Talking very briefly about the pathophysiology of the acute or chronic right heart failure, there are basically 4 mechanisms involved, namely excessive preload, excessive afterload, reduced contractility, and last, reduced lucitropic agents. All these 4 mechanisms are interconnected with each other and ultimately leads to fluid overload, or in other words, volume overload and pressure overload, compromising the perfusion of the right ventricle, ultimately leading to havoc called right heart failure. On the other hand, we cannot ignore the pulmonary hypertension status as well whenever we are talking about the right heart failure. Pulmonary hypertension is defined as an elevated mean pulmonary artery pressure of greater than 20 millimeter of Hg when the patient is at rest. The degree of risk and appropriate management differs with the severity and type of the pulmonary hypertension. Patient, if being asymptomatic or mildly symptomatic, may only require close monitoring as far as anesthesia is concerned. However, when the disease is more substantial, you need to have more intense monitoring. Talking about the etiology, pulmonary hypertension can be easily divided into 5 different categories. Pulmonary artery hypertension, which is exclusively being the precapillary portion. Pulmonary hypertension secondary to left-sided heart disease. Chronic thromboembolic pulmonary hypertension. Pulmonary hypertension due to lung disease or hypoxia. And pulmonary hypertension with unclear or multifactorial mechanisms. Right, so talking about the pre-anesthetic consultation, we can subdivide it into history, physical examination, investigations, optimization, and the most important thing, anesthesia plan. Talking about the history is mainly reviewed to assess the patient's symptoms. That includes fatigue, dyspnea, shortness of breath, or syncope. The functional significance of pulmonary hypertension by measuring the exercise capacity of the patient. The patient's New York Heart Association classification, and other comorbidities involving various other systems like renal, neuro, hepatic, and other systems. Physical examination is mainly focused on the failure signs and symptoms. These include assessment of the volume status, peripheral edema, jugular venous distension, hepatojugular reflex, hepatosplenomegaly, valvular defects like tricuspid regurg. Preoperative testing include both non-invasive and invasive investigations. It's highly imperative to highlight here that the important investigation should be mentioned to the patient whenever there is an implication that the results of the investigations will help you in your peri-operative management. Like ECG, echo, ABGs, chest X-ray, all these help us in finding out the status of the cardiopulmonary status of the patient. If the patient is, for example, on long-term diuretics, there must be an expectation that the patient might be suffering from electrolyte imbalance. Hence, the electrolyte levels should also be found out. Whereas, on the other hand, the invasive investigation, we have right-sided heart catheterization, which clearly indicates us the status of the patient, whether the patient is suffering from pulmonary hypertension, how severe is the pulmonary hypertension, and what perioperative measurements can be taken in order to keep the patient stable, and what will be the result of those perioperative measurements with regard to the severity of the patient's status. This is one of the main important points which we easily ignore while doing the preoperative assessment of the patient. That is obstructive sleep apnea. That can be an underlying cause of hypoxemia that can exacerbate significantly pulmonary hypertension. Thus, screening for OSA should be a routine part or practice of the pre-operative evaluation. Next is optimization. Management of chronic medications which are being used by the patient in order to stabilize himself or herself as far as pulmonary hypertension or right-sided heart failure is concerned. These include usually prostacyclins, endothelin receptor antagonist, or cyclic GMP antagonist that includes mostly phosphodiesterase inhibitors. Other medications to manage heart failure like ACE inhibitors, ARBs, various diuretics, and in the end, anticoagulation medications, which needs to be stopped depending on the status, individuality of the patient, the drug which is being used by the patient, and the surgery, whether it's a minor one intermediate one, or a major surgery. And last but not the least, you must know the intravascular volume status of the patient and should optimize accordingly, because heart at this level is very sensitive to volume. Next is control of exacerbating factor that might exacerbate the right heart failure or the pulmonary hypertension. That includes continuous oxygen administration, treatment of exacerbation of lung disease, treatment for OSA, and lifestyle modification in selected patients like cessation of smoking, exercise, and various other things. There are other options like mechanical circulatory support in terms of supporting the left as well as the right ventricle, provided it's secondary to the left heart failure. That includes IEBP in left ventricle assist device, right ventricle assist device, and VA ECMO. ICD pacemakers and pacemakers are being routinely found in the patients who are suffering from heart dysfunctions. And it's important that they should be correctly identified, and the status of the pacemaker ICD should also be identified before the patient is brought into the OR. Preoperative sedation consideration should also be looked into, but it's important that the patient shouldn't be suffering from hypoxia secondary to sedation, which can ultimately exacerbate right-sided heart failure and pulmonary hypertension. Anesthesia plan. Well, it's a tricky one, but it's important that you should know the patient's status, surgical status, and what the surgery the patient is going through, and what will be the best as far as the patient status is concerned. Choice of anesthesia technique is briefly based on the surgical procedure and its impact on pulmonary hypertension. General anesthesia incurs significant risk of adverse hemodynamic and respiratory effects. However, it's important that peripheral nerve blocks and or sedation with monitored anesthesia is preferred for minor surgical procedures whenever there is a chance to take it. Neuroaxial anesthesia may be safe as long as hemodynamic stability is assured. If neuroaxial technique is selected, an epidural technique or combined spinal epidural is preferred over alone spinal anesthesia. However, there are certain specific preoperative mortality moderators as well. That includes elevated right atrial pressure greater than 7 millimeters of Hg, right ventricular hypertrophy, 6-minute walk distance of less than 400 meters, history of pulmonary emboli in the past, and perioperative use of vasopressors preoperatively, along with major surgery and long duration of surgery of greater than 3 hours. Now, going into the intraoperative management, avoiding factors that increase baseline pulmonary vascular resistance, maintain preload in an optimal range while avoiding fluid overload, as well as avoiding hypovolemia as well. Maintain pulmonary artery pressure as low as possible so that the forward flow of the blood in from the right ventricle into the pulmonary artery is helped. Avoid tachycardia and maintain sinus rhythm. Now, there are a lot of modalities through which we can monitor the patient. That includes standard monitoring in terms of ECG, non-invasive blood pressure monitoring, pulse oximeter. However, there are certain surgeries depending on the status of the patient might need intra-arterial catheter, central venous catheterization, pulmonary artery catheterization, which also helps us in finding out various derived and measured values as well. However, one of the major things that has provided as far as the promotion of the cardiac anesthesia is transesophageal echocardiography, which not only give us an impact on quantitative, but also give us an impact on the qualitative status of the patient's heart as well. Starting with the induction, ideal is short-acting hypnotic agent such as etomidate, moderate dose of an opioid which can be fentanyl or remifentanil. Muscle relaxant ideal is rocuronium. However, other muscle relaxants can also be used depending on the preference of the anesthetist and the patient status. And there are major adjuvants which can be used at the time of inductions as well, like magnesium, xylocaine, and dexmedetomidine. The entire objective of all these measurements is to control the sympathetic drive of the patient to the minimum level as possible. Selection of inhaled anesthetic agent for maintenance is based on their effects on the systemic and pulmonary hemodynamics. Next is management of ventilation. Balance is maintained in order to provide adequate oxygenation and ventilation, avoid hypoxia, and strategize the factors that may decrease the FRC, which can ultimately lead to increase in thoracic pressure and decrease oxygen levels. Both PCV and VCV modes can be used depending on the situation and preference of the anesthetist. Like already mentioned, RV preload is maintained as far as the fluid management is concerned. Avoid intravascular volume overload as well as hypovolemia. CVP should be maintained to the minimum level. Abrupt changes in intravascular volume status should be avoided. Right, so there are chronic targeted therapy for pulmonary hypertension. As early as I have told you that there are 5 different groups. The group 1 being the pre-capillary disorders as far as pulmonary hypertension is concerned. There is dilation of pulmonary artery is the ultimate target. And we have certain options for that as well. That includes intravenous prostaglandin therapy, that mainly includes prostacyclin, which can also be found in the forms of inhaled variety as well. Next is nitric oxide inhalation that has proved to be a greater blessing as far as managing the patient for pulmonary hypertension and right-sided heart failure is concerned. And intravenous milrinone. Talking about the group 2 pulmonary hypertension, that is basically secondary to the left-sided heart failure, it's important and imperative to highlight here that we cannot use the vasodilators or the pulmonary vasculature dilators here. The reason being, there is increased volume of blood or volume to the left atrium, which can significantly exacerbate the failure status of the patient. So what are the options then? You simply treat the patient as being a failure of left-sided heart failure in this scenario. That is perioperative diuresis, intravenous milrinone. However, there are certain cases where certain management has been diverted towards using inhaled nitric oxide. However, preference is to avoid the inhaled nitric oxide as much as possible in this scenario. This is one of the article which I have just shown here, which clearly shows that inhaled nitric oxide has been a blessing when you are treating the patient or managing the patient with type 1. However, this can create exacerbation of the pulmonary hypertension and right-sided heart failure in type 2 pulmonary hypertension. There are certain vasopressors and anatropes which can also help us in maintaining the perfusion pressure for the vital organs. Starting with vasopressors, the primary and the most supportive being the norepinephrine and the vasopressin, which decreases the pulmonary vascular resistance ratio to pulsosystemic vascular resistance. However, the vasopressin, if used in low dose, can actually cause pulmonary vasodilation as well. On the other hand, we have certain inotropes as well, like milrinone, dobutamine, dopamine, epinephrine. Each becomes or comes with its merits and demerits. And there are mechanical circulatory support as well, like right ventricular assist device, biventricular assist device, and extracorporeal membrane oxygenator. The emergence from general anesthesia is the ultimate goal, which is usually done through smooth emergence by controlling the increment in the sympathetic drive, just like what we did at the time of induction. That is done by adequate plane control, avoid hypoxemia or hypoxia, avoid hypercapnia, and avoid temperature derangements. The postoperative management, whether in the ward, HTU, or ICU, basically depends on control of pain, preload, heart rate, systolic blood pressure, ventilation, temperature, continuation of the PH therapies, and intensive care unit in selectively critical patients. The take-home message is assess your patient's severity and cause of the right-sided heart failure. Don't go or manage the patient blindly. Always plan perioperative management according to the patient's status and surgery. And avoid factors that can exacerbate the right-sided heart failure and all pulmonary hypertension. Thank you.
Thank you very much. Our last talk of today's session is by Dr. Asma Abdul Salam, and topic is cognitive behavior therapy, a complete replacement of chronic pain intervention. Dr. Asma Abdul Salam is currently working as assistant professor, consultant anesthesiologist and pain physician at Ziauddin University Hospital, Karachi. Notably, she spearheaded the establishment of hospital first pain management service and served as a program director for anesthesia. She is the director and organizer of many courses and workshops on pain management. She is current General Secretary, Pakistan Society of Anesthesiologists, Karachi chapter. Please welcome Dr. Asma.
Thank you so much for inviting me for this talk. I have no conflict of interest, but have a disclosure that food is ready, and inshallah this is our last presentation, so I won't take longer. I won't delve into the definition of pain, which was revised 2 years ago by ISP. But definitely chronic pain is a multifactorial condition that has biological, psychological, and social contributors. How much each domain contributes to a particular patient varies from one patient to another and over time as well. And although there are various types of chronic pain and different measuring components of the chronic pain, the International Classification of Diseases, ICD-11, have classified 7 types of chronic pain in primary cancer, post-traumatic, neuropathic, headache, orofacial, visceral, and musculoskeletal pain. For decades, the Global Burden of Disease study has ranked the chronic pain as the world's greatest cause of disability, ranging from 7.1% to 61% in our region, especially common in older adult population. Kindly keep this picture in mind because this is the pain pathway, but with the core 3 components, including the nociceptors, which detects the pain signals, the spinal cord, which transmits and modulates the signals, and the brain, which processes and regulates the pain experience. However, in chronic pain, there are certain differences in which the nociceptors, they become hypersensitive and can be activated by the normal sensory stimulation. These signals are transmitted by A delta and C fibers to the dorsal horn of the spinal cord. I'll try to be a bit fast in it because this is just a common concept about chronic pain. Then the dorsal horn is the first site where the pain signals they enter the spinal cord and where the initial processing and modulation occurs. But in chronic pain, there is increased neuronal excitability and reduced inhibition, amplifying and dysregulation of the pain signal transmission. And then there is a third component in the chronic pain, which is there are changes in the volume and connectivity of these spinal tracts, which correlates with the chronic pain intensity and modulation. Pain signals, they are processed and modulated in various brain regions, including thalamus, brainstem, and brain cortex. However, in chronic pain, multiple brain areas, they exhibit functional and anatomical changes which disrupts the normal pain modulation. So why I am discussing things again is because this is why chronic pain is difficult and challenging for management. Different pain-related behaviors like maladaptation, unhelpfulness, provocative behavior, they are very common in chronic pain patients. These are also associated with depression, insomnia, fatigue, and physical deconditioning, which often creates barrier in the recovery of such patients. So in short, chronic pain, it leads to reduced daily activities, it reduces the social interactions, patients are socially withdrawn, and that's why they lack empathy. Empathy, again, has 2 components, which are cognitive and affective. And then patients, they go into pain catastrophization, which includes that they magnify their pain stimulus, they feel helpless, and they are unable to inhibit the pain-related thoughts. So there are a lot of interventions to influence these towards improving the physical, psychological, and social function and the quality of life. Behavioral interventions, they can be brief and they can be long, and overall they improve all of these factors. So the cognitive behavioral therapy, it is a very popular and promising psychosocial treatment approach among different psychological treatments. And it is a short-term psychotherapy ranging between 5 to 15 weeks. CBT has the advantage of being a structured, theoretical-based and evidence-based psychotherapy, and that's why it's called as structured, theoretical, and evidence-based. So the pain it is based on the theory of the gate theory, which has been proposed earlier initially for the pain pathway. And it emphasizes that the subjective experience of pain is not only a biological product, but also a product of perceptions, emotions, which involves regulations in the mind. And the main goal of CBT in treating the chronic pain is to increase the functionality overall. But otherwise, it also decreases the pain severity, cost of hospitalization, opioid consumption, and it does not have any major side effects. So what actually does it modifies the physical sensations, it decreases the catastrophic thinking, and it decreases the maladaptive behavior. By having an increase in the opioid beta endorphin expressions, and it is also thought to decrease the inflammatory factors like interleukin-6 and TNF-alpha. So there are 3 fundamental components of CBT, which are psychoeducation, coping skill training, and application and maintenance of the learned coping skills. And these are different techniques in which the cognitive restructuring, relaxation techniques, and behavioral activation are the most important ones. So now if we think that CBD, has it ever come to that point, that has it ever changed the treatment plan in the chronic pain management? Definitely we do have challenges. Patients, they often have high expectations of complete pain relief if only a CBD is given with the minimal time cost and effort. And it also enhances the anxiety among the patients as well as with the clinicians. And clinicians are caught between seeking the patient's satisfaction, time constraint, and the concern about insurance coverages in some places and in some countries as well. So the challenge to produce an informed guideline for the CBD in the chronic pain management will mean that the therapists will have to rely on their own experiences, their own clinical judgment, and their own knowledge to plan the CBD module in the chronic pain management, and it would be varying among patient to patient. So can CBD be a standalone solution for the chronic pain? There are a lot of studies which have been done. Evidence quality shows that CBD outcomes has ranged from moderate to, in fact, low. There are evidence of different studies in which CBD is considered very safe with minimal risk. However, comorbids, psychological or cognitive deficits, they may require pre-screening and adaptive protocol under supervision to prevent the adverse events like further anxiety and further confusion or withdrawal from the treatment as well. Supportive and guided exposures may improve safety and tolerability overall. But techniques, they should be tailored for the vulnerable population, especially those who are in chronic pain. There are multiple studies which have been done on CBT. Sorry, Mike. Yeah. So there are multiple studies which have been done on CBT and its different components like empathy, depression, the other scores which assesses the CBT and the chronic pain management. Somehow they have always shown that until unless the CBT is used in conjunction with multimodal analgesia and multidisciplinary approach, it won't have more effect. So last year's global, IASP's global theme was integrative pain care, and even there it was mentioned that patients should be, the treatment model should be patient-centered. It should be temporally coordinated, mechanism-guided, individualized, evidence-based with the integration of multiple pain treatment interventions. So CBD has beneficial effects on reducing pain, disability, and distress in chronic pain patients, but definitely optimal pain management, it requires interdisciplinary care, and it includes determining the optimal frequency, intensity, and duration for achieving the best outcome. So thank you. Food is ready, and I hope you are all well with it. Thank you so much.
Okay, thank you very much. Can we call the speakers over here for question and answers? आप भी आ जाइए मेरे पास.
We have time for only 2 to 3 questions. So there is a request, please keep it brief. So audience, any questions?
What is the incidence of right heart failure in patients with OSA? Any studies?
Sorry, sir, come again.
What is the incidence of right heart failure in patients with OSA? I mean, you told that it is a cause of right heart failure.
So,
one of the causes.
Unfortunately, I didn't come across any statistical analysis as far as these two things are concerned. But what I found out in the various articles that I was searching through was that this is one of the major commodities that has been ignored easily while you're doing the perioperative evaluation of the patient who has already been suffering from right heart failure or pulmonary hypertension.
Any other questions? So there is a comment. Mike, please.
CBT. CBT is a very interesting topic. CBT is in fact a very interesting technique, you can say, a very interesting topic for chronic pain management. And but whenever I've tried a lot to involve a psychologist in my own clinic or my department, and whenever I involve, most of the time the young psychologists, when we ask them, Do you know how to, what is CBT? He said, यहाँ पढ़ा तो था. ठीक है, CBT पढ़ा था, अब कभी किया, नहीं किया, कभी सीखा, नहीं सीखा. CBT करते कैसे हैं? CBT itself, we need some experienced psychologist with. You हमने नहीं करना. हमारे लिए तो बड़ा मुश्किल है कि हम दोनों काम करें. हम जिस हद तक कुछ ना कुछ psychological management अपना patient का, along with the chronic pain, yes, it can't be a substitute for the primary जो हमारी interventional treatments हैं या physical methods के साथ हम करते हैं. Substitute नहीं है, उसको complement कर सकता है. But if we have a competent psychologist who is experienced in that, तो फिर ये एक अच्छा combination बन सकता है. It can work.
Thank you, sir, for the comments. Exactly, you are so right. Initially, CBT was being treated, patients were treated with CBT by most of the psychologists and the psychiatrists. But over a period of many years, and even I think few months ago, Dr. Gohar at AKU, she also conducted a program on CBT with the workshop, and where we were, all the pain physicians, they were invited for have a training session on CBT. So actually it's a new thing which is coming in, and we are being trained on how to counsel such patients, because it's not a simple one-day kind of a therapy with which, and likewise chronic pain management and the chronic pain patients, they are also those patients who have been suffering for like years and years, and they are already on so many medications. So CBT actually dissociates that kind of a pain, and it actually helps alleviate what the patient might be suffering otherwise. It's not a single standalone kind of a therapy. It definitely needs other therapy as well. But yes, we as pain physicians, we are not totally trained in it, and exactly you must have seen that the references which I was quoting, they were mainly from the psychology and the psychiatry annals or the journals, instead of anesthesia or the pain management. So now it's the new modality which is coming in, and now the chronic pain physicians, they are working on it and working along with the psychologists.
Can I ask Kamal?
Ma'am, just a request that can we please have the QR code on, so
sure.
that the rest of the people can scan and
Please
have
display the QR code.
How often is a minimally invasive esophagectomy done in the UK? Is it very common, or is it just restricted to certain hospitals?
It's because esophagectomies generally is becoming more centralized, so specific units within the UK will do esophagectomies. They're trying to get rid of those units who do something like 10 a year, because they don't get the skills, and there's some evidence that those hospitals that only do 10 a year have poorer outcomes. So they're trying to centralize it in about 20 hospitals in the UK. So those hospitals that do get, the majority of them do at least 100 a year. So in 10 years, I personally did about 300. That's minimally invasive esophagectomies. And the outcomes became the best in the UK as a result of us doing this enhanced recovery program. So everyone was trying to emulate our results and centralizing everything within the various regions within the UK.
One question
Okay, I have a
for
question.
Dr. Kamal.
Yeah. Just Dr. Kamal, yeah. You talked about carbohydrate giving pre-operatively.
Yes.
Does it, how much, and does it help in the recovery of such procedures, minimally invasive, or it has no point?
It's difficult because no one's really researched in esophagectomies specifically. This is all we haven't actually researched it. This is all extrapolated data from colorectal surgery. We know colorectal surgery does improve the insulin resistance and the protein losses. So in my experience, the blood sugars actually don't fluctuate as much during the operation as they did when we weren't using it. Because we didn't start off with carb loading from word go. We said, let's try it out, see if it works for us. And I noticed, not evidence-based, just from personal practice, that it wasn't fluctuating. I wasn't needing to start insulins and stuff like that, where in the past I had to.
can do a research on that.
Oh yeah. There's a lot of scope to what we do now. Yeah.
Question for Dr. Kamal.
Yes.
You said that for post-operative pain, you don't prefer these epidurals.
Yes.
Because there can be possible complications. What is the most common technique for post-operative pain which is employed in your department?
For post-op, in what regards? With the esophagectomy or generally?
Yeah, for this minimal invasive
Esophagectomy. So,
what is the approach, surgical approach for minimal invasive, and what area is to be blocked for that? If you have to give some regional block, you said paravertebral can work very well.
So I didn't hear the last bit, the last comment that you said.
What he wants to know is that what is your practice
Yes.
of post-operative pain relief,
Yes.
and what is the approach? So, what do you usually use? The serratus plane block, or the PEC, or paravertebral, or what block
I
do
got
you
you.
use?
So what we generally do, we start in theatres, so it's not. So we start with paravertebrals, as a long-term relating to post-operative care. But even before that, apart from the usual paracetamol, magnesium, fentanyl, which we give small doses of, we do intercostal blocks. I personally do intercostal blocks, do spinal with morphine, low dose, rather than a high dose. I don't go into the milligrams, I'm in the mics region. So I give about 250 to 300 mics at the beginning of surgery. Because the morphine is less lipophilic than, say, diamorphine, it lasts longer for about 24 hours, if we're lucky. And that's supplemented with the intercostal blocks that we do during the thoracic phase. And then the surgeon or myself would put a paravertebral in, or subpleural catheter. And we run an infusion through the paravertebral or subpleural catheter. Similar to an epidural infusion. It's exactly the same rate, same concentration, without the fentanyl. And then if there's breakthrough pains, all the registrars or trainees have been taught to do intercostal blocks as a supplementary thing. What I would do differently now, if today I was doing an esophagectomy, I would put an erectus spinae block rather than... that's a personal opinion.
And that's what I was going to ask. Don't you use erectus spinae? That seems to be becoming more popular.
Yes, it's coming in trendy now, yes. Or has been in the last 3 years, 5 years, as more evidence comes out.
Thank you, everyone. Thank you, everyone. For certificate distribution, I would like to invite our honorable chairs to present the certificates, please. So, Dr. Kamal Al-Naimi. Dr. Asad Latif. Dr. Jodat Salim. Dr. Khalil Shibli. Dr. Haris Chauhan. Dr. Asma Abdusalam. Now I would like to invite Professor Safia Zafar to present certificate to chairs and moderator. Professor Ashraf Zia. Professor Naila Asad. Dr. Malika Hamid. Thank you everyone. Lunch is served. The participants and delegates are requested to proceed to Governor Room, and the senior faculty and executive members are requested to proceed to Dampukt. Thank you.